Now I think we have a discussion about the prospects of geriatric education, geriatric specialty in different Balkan countries.
Maybe just one brief additional comment to what Professor Zamboulis has just said. There is also from the side of European Geriatric Medicine Society a clear intention to involve more closely Balkan countries in the activities of our society. This symposium is a part of not only short-term but also long-term strategy. With regard to the short-term, of course, we are all I would say hopeful that much more participants than in the recent past from these countries would attend our next Congress in Athens. But also in the long term, we would like to more closely involve these countries, particularly younger people, to engage in the activities of European Geriatric Medicine Society and to intensify collaboration with our society. So we are also from the European Geriatric Medicine Society, we are at the disposal of the colleagues from these countries, and already today we had a preparatory meeting. This symposium also is a very nice proof of, I would say, beginning activity in these countries in terms of geriatric medicine, and we are at your disposal to further stimulate mutual interactions, but also interactions between respective countries and our society. And today, this afternoon, we had a very fruitful preparatory meeting with some of you. Maybe we can start with some reflections that already have been indicated this afternoon. Nenad, maybe you can start because you provided some very helpful comments this afternoon, and then the other colleagues can join.
Okay, thank you for this surprise invitation. But hear me? Yeah. Yeah, I mean, when I'm looking all this presentation, we probably suffer of the same disease as a geriatrician. I mean, first is education, which is definitely underestimated in our medical faculties. There is postgraduate education, which is still suffering of some kind of systematic type of specialization, which we probably need. There is the clear difference north and south on the European level. Probably northern countries are developing the specialization of the geriatric, try to define what is the field of geriatrics to escape this animosity with other specialization. You know, honestly speaking, I think every doctor is supposed to be even in the small part of his specialization, geriatrician. Exception pediatrics, because the part of aging is definitely an inevitable part of every specialization in a way. But still, as a geriatrician, I think we still have good potential to show that we, with our assessment and our focus, is to estimate the rehabilitation potential of those patients, regardless are they a single or multi-diseased. So in the discussion today, we talk two things. First, who is a hub? Who is a person of first contact of these patients, this type of patient, and what are the minimum demands that we can make a screening in the very wild population? What stuck me here is my first question is, can every single person, age person in every country has the same chance to be assessed? I mean, we have hospitals, we have discharging, but I don't think that in every corner of the country that you will have the same chance to be you approach to the doctor and get a proper assessment. So then the question is definitely falling down on the GPs, and the GPs as a first contact of those patients. I don't think it's only GPs. I think it's a team GP. I deeply think that the nurses in the GP settings should be the partner in the assessment and screening. If you ask me what I think of screening, I think a screening of the two geriatric giants. This is sarcopenia and the frailty and definitely cognitive impairment. This is the three things which, according to the guidelines, which is recently published, should be put on the level of the primary care to build up this base and the database and sometimes the knowledge about a certain patient. We talk today about pre-risk of the operation. For me, it's much important post-surgery risk of delirium and confusion, which I found is much more deliberate for the dose patient than the pre-risk. And so my first idea or question to all of you is who are the persons of the first contact for the geriatric patient in your community? What is a minimum education that we can demand, and what is a minimum screening for this type of geriatric population, which we can ask? If we start with these three questions, maybe we can develop further.
Okay, no, but go ahead. I can speak it later.
Oh, okay, thank you very much. We had some problem of this kind in our country because we tried to develop both the curriculum and the education in geriatric medicine and a network of geriatric medicine. So these are two interconnected aspects. We cannot develop academic undergraduate and postgraduate geriatric medicine without offering them a network to work in. So, and the easiest way in our country at least is to develop an outpatient network because it's the cheapest. It's just a doctor and a nurse and a room. And it's very difficult to develop an inpatient. As you have seen in my presentation, the beds did not increase very much. Just a couple, 50 or 40 beds in 5 years, because there's a trend to decrease the number of inpatient beds. But the outpatient is very important. Why? First of all, you offer a perspective to the graduates, those who graduate the training in geriatric medicine. Where should they go? And if you have a coherent network of these geriatric clinics, outpatient clinics, you can offer them a perspective. Moreover, you have a human resources basis. If you want to develop other services for geriatric, you need a human resources. For example, we try to persuade our policymakers to pass regulation so that all nursing homes should be seen by geriatricians, not by family medicine. And the question was, do you have enough human resources for that? And we answered no. I think we have to start these two approaches. So it's very important. And there's another advantage, because you can offer a help to family physician. Of course, as Professor Nenad Bogdanovic says, you cannot work without family practitioner. Actually, all specialists work with family practitioners. They are turning point. They as a hub can be used, as Professor Nenad Bogdanovic said. But it's in a way easy to handle this problem if we are doing properly, because the question is what patients should be referred to geriatricians. And you have several tools. First is history taking. The family physicians, they know their patients, their pool of patients. They have followed them for many years. And they can assess them, even starting from day-to-day living and a lot of information they have, not only through specialized tools. And this is the first screening they are performing. Second screening, maybe they need some tools, some very simple tools, to separate the patient who need to be sent to the geriatrician and those who can be followed up by themselves. And this, as we discussed this afternoon, one is very important strength of the hand grip. This strength of the hand grip, it's a very important indicator, and several studies showed that it's an independent indicator for many other complications and problems. And it's not very complicated to be performed at the GP level. And second, a simple tool for screening cognitive problems. So I think these two aspects are possible to help general practitioners to discriminate between those who need to be referred to geriatrician or not. And of course, history taking, their experience, because they follow up for a long time, and maybe this tool could do the trick. Otherwise, as you have seen in the presentation, general practitioners are overloaded with work. Many patients come to their offices, and it's impossible to deal with them. But the most difficult patients in their practice are some of the older patients, because they consume a lot of time. And this way, they can send them to geriatrician and save their time and deal more with adults and younger people. This could be one solution. Thank you very much.
Yeah, maybe I can give just a point of view. Working for the last, several decades in France, which is a country with developed geriatric medicine. Because it's always, finally, the big question we have, and mainly when we are in countries where geriatric medicine is not very developed, is all the discussion we have with the other professionals, especially the other colleagues, saying, okay, do we need a geriatrician? I see all patients, the cardiologists say, the neurologists say, the dermatologists, everybody. So I see all patients, I know the problems, okay, it's medicine, and I know that these persons are more vulnerable. So this is a big question. And I think that when they ask young, students, physicians, whatever, ask that question, I think there are some major things. Let's say, but maybe you have another opinion. This is why I like a little bit, to stimulate this discussion. First is, I think geriatric medicine is, first of all, an expertise. To say that, to understand the problems the very old person or the old person has, you need specific knowledge. It's not, of course you said time, you're right. Time is important, and we have everywhere this problem. Because a consultation, when I see I'm an original cardiologist, maybe you know it. So, consultation cardiology, it was, 10 minutes, 15? A patient I know already, it's 10 minutes, 15 minutes in the hospital. I'm also in the hospital. Even a patient I know very well in geriatrics, it's never less than 40 minutes, never. I can't. Maybe, unless from very, very rare situation, they come for just one question, something like that. But anyway, but in addition to time, of course, it's a lot of knowledge, medicine knowledge, medical knowledge, internal medicine, general specialties, but all this what we are talking about, evaluation, assessment, and so on. So expertise means what the topic of this meeting is, which is how do we work with the neurologists, orthopedists, surgeons, whatever, another, cardiologists, whatever. This is one. The second thing I think, which is very, very important, is that the geriatrician knows better than anybody else that the organization, and you told, I think, you and other people, of the geriatric medicine, it's like a chain, it's a pathway, which has to be first developed, means outpatients, day hospital, acute departments, rehabilitation departments, long-term, and the connections of all that with the city hospital networks and the general medicine. Otherwise, you cannot do geriatric medicine. Geriatric medicine is not to have a very good acute care department isolated somewhere and to see, okay, you can do medicine as any cardiology, internal medicine department. But if you don't have the other structures, and if you don't have the articulations with the other structures to work, and if the patient, the geriatric patient cannot be at the right moment, to the right place, but it's in another structure. Someone today or yesterday, today, showed that, if the patient stays somewhere where he doesn't need this type of care, I mean, the only thing he waits is for the next nosocomial infection or something like that. So it's very important to understand and to make that, and we have this let's say, preoccupation in France. It's extremely, but not only France, but I work in France. It's extremely important. How, when we send students, I'm the University Hospital of Lorraine, Nancy, but when we send the new people doing, I mean, the new doctors doing geriatric specialty now, or even students to the other units outside the university hospital, the thing we want to know if these units have developed all the different parts of this chain, of this way, or if they have close relationship with the known articulations with other structures that have the other parts. Otherwise, you cannot have developed geriatric medicine. And the third, and they finish with that, the geriatrician is, even if it's the principle of any medicine, theoretically, the geriatrician is the physician that having all these knowledges, theoretical, as we said, the first part, the expertise, this kind of chain and pathway. The third thing is that to do all that, he knows that he cannot do it alone. It's not a big king that has some small assistants to help him. He has to work in network. He has to work with other specialists, but with other health professionals. And sometimes often he will be maybe the regulator, but most of the times in France, the pivot person is the GP, for instance, most of the times, not the geriatrician. And this is good. This is the system, but it works rather good. And of course, with many other, we know, psychologists, physiotherapists, ergotherapists, speech therapists, social assistants and so on. So it's very important. Otherwise, it does work. Again, you cannot do geriatric medicine only with doctors. Basta, as we say. It's not possible. And because you have to take into account what we call the nice word, very Greek word, holistic approach. And this holistic approach, one person cannot do it if it's the most intelligent person. Okay, just to stimulate the discussion, I think it's important issues. And maybe one question, if someone, I would like in your countries, how are your relationships exactly with the other physicians? Do they respect you in terms, they recognize your utility, or it's just, well, okay, as you said, they called you one for maybe the father of the president of your something, yeah, something like that, vice president.
I agree with. Sorry.
If you finish, Athanase? Okay. I would like to ask Professor Martin Fibram, who was initially clinician internist and then in the last year became a geriatrician, your thoughts about the specialty of geriatric medicine.
I think I've been a geriatrician for a long time, actually.
Oh.
Yeah, so I think in our conversation I probably wasn't clear enough. Yeah, no, I've been a geriatrician since 1982.
Okay, then I will speak. I think to become
as well as an internist.
Okay, to become a geriatrician and to give care in hospitalized patients, you have to have a very good training in internal medicine. It's essential. I don't know if the general practitioner have enough time to go into deeply into the internal medicine with 6 months education in internal medicine. I think if we have geriatric department to hospitalize pneumonias or other medical, other internal diseases, you have to have a good training in internal medicine. It's essential. What's your opinion?
In all curricula of geriatric medicine, you have a very good training in internal medicine.
Yes.
I think Yanis wanted to say something. I'd like to come back to your question later in conversation.
I agree with everything you said, but I find also a political issue how the health departments, the choices of the public health departments. What I mean is, how many geriatricians do you believe that there are in UK? I found in the census, the last census, that there are 1,600 geriatricians and 600 internal medicine. So the country said that we are going forward, creating geriatricians, because these are the needs of the population. I guess they went this way forward, and we are creating enough good doctors, very good physicians, because this is what they are. And also, they have all the structures that Professor Benetos said to deal with the problems of the older people. So, therefore, they are respected. They have, because they are in a large number, they can be contacted by anybody who needs to be seen by a geriatrician. And any hospital, who are you going to speak with? With a geriatrician. The surgeons, who they are going to call for an evaluation? A geriatricians, because they are there. They have established themselves. So it is a question of numbers. If you have a country, a friend of mine, they said that in Spain they have 250 geriatricians. They cannot have the impact that we are discussing today. If you have 40 in your country, you will have 2 in Greece, or some centers that they try to do what geriatricians normally do. We cannot achieve the critical mass to change the mentality. This is my point.
So, geriatricians should be hospital doctors.
I just want to say briefly, I agree with the situation, Yanis, that the UK has many more geriatricians, and therefore we're able to do more. But I'll be absolutely straightforward. We didn't get to that by saying we need many more geriatricians, and then we can do more. That is not how we made the transition. So, well, no, we responded, but I don't. It would be wrong to say that our public health system had the vision 15 years ago to say we need so many more geriatricians. Therefore, let's create them, and then they will be enough to respond. It's a much more iterative process than that. It's much more staccato. It's much more iterative. So, for example, as the solutions develop in a way that carries confidence in response to the problems, then it's possible for the public health system to recognize that they want to scale that solution up. But they don't have a concept of a scaled solution if they haven't seen the solution at lower scale. But the reality, in any case, is that people are starting from a very different place. If we assume that there is one relative constant, and that's the nature of the health problems of the older people is roughly the same, we've got a number of other things that are not the same. And one of the questions I think strategically that we have to come to is, do we think that there's a solution that will fit the different contexts of the different countries that we've heard about? Or do we think that it would be useful to articulate a range of solutions, relatively confident range of solutions, that that individual countries can decide which is the door that seems to be open? That may be the solution we can develop, because you won't connect the connected service that Athanase is describing is the end product. Now, I believe very strongly in our country, and I think it's probably the same in your country, that if you said that the solution to all of this is a very large number of expensive specialists, you will get nowhere. But what you can do is articulate the structure in terms of the needs of an older population that they need a type of response in primary care, they need a type of response in nursing home, they need a type of response in hospitals. to be able to then say, and we geriatricians can not only provide that vision, but provide the practical solution here and there, but there are other players who have to provide their part of the solution, I think we're much more likely politically to get support for that argument. So to come back to your question, therefore, do I think a fully fledged geriatrician is predominantly a hospital-orientated person? Yes, I do think that's the case. But I think that our vision for developing geriatric sensibility in the system, which I think we need to lead on, requires other practitioners to emerge from other places. But I don't think that the vision is likely to come from somewhere else.
May I add something? Oh, yeah, Josh.
I want to comment something. This is I'm a primary healthcare physician. I am a GP, and I have been trained in geriatrics. And the approach you are mentioning, it's typically a hospital-centered, approach. Medicine is done only in the hospital. Quality medicine is done in the hospital. So let's admit that. Where's the place for the Icop model in this model? There is no place on the Icop model in this model. So you think that the hospital is going to organize, the healthcare provision in the community level? No, it's not going to organize healthcare provision in the community level. It's different things. It's different geriatrics in the community. It's different geriatrics in the hospital. And let's admit, we have to train, primary healthcare physicians to be more sensible in terms of geriatric evaluation, but we can also produce geriatricians trained to work in the community.
Yeah, I would
because
like to,
it's a continuity of care, you see.
Just one second. What we said is that geriatricians are mainly in the hospital, not geriatric medicine, geriatricians in the hospital. This means that, and the geriatricians have to train the GPs, because the geriatrician is, in France, there are 2,000 full-time geriatricians, all working in hospitals, 2,000 exactly. There are at least 5,000 people with geriatric let's say, capacity, as you know, okay? And these people are the connection, as I would say. I said, what's important in care about geriatric patients is the connections with hospital and the community and the networks and the GP. So the GPs with this knowledge is very useful, and the geriatrician has to train. So I didn't say, and you know that, that it is to do that, all this expertise to stay. For instance, preventive geriatrics has to be primary care. And you know that the programs we developed. So, but the geriatrician who is mainly in the hospital can give that this expertise. And just to finish, when I insist and say, attention, the private geriatric medicine outside the hospital can be dangerous, because we see some geriatricians that open their clinic or small business, and finally, if you are alone in like a geriatrician, isolated, you finish by doing anti-aging medicine instead of doing real geriatric medicine. This is why I say, attention, the private, outside the units, not only a hospital, so big units, it may be okay, but it may be also dangerous. But this is the spirit. I think it's important. I give you the...
Yes, I agree with you all that the need for geriatricians and the need for geriatric medicine depends on each country and different conditions, society conditions, existing services, and my experience from my country, Greece, is that we need geriatricians on an academic level. We need academic centers. For example, I cannot imagine a whole Greece without an academic center in Athens with geriatrics training, even pro-graduate and postgraduate. And I think we need more than one academic center. Also, we need consultants, because we need to show this multidisciplinary approach and the integration in the care in the hospitals, where all doctors come for residency and became specialized. So they need to see and understand how is the interrelationship with the other professionals and what is geriatrics. And then we go to the primary care, and I think that all the primary care is not only general physicians in my country. It's many other physicians, internists, and surgeons. Even these give the primary service, because it's not only public sector, it's also private sector. Many Greek citizens do not decide to go to the public, to the Tomis, public. They go to the private doctor. So the physician, the primary physicians, they need to know geriatrics. So every primary care physician, a family doctor or GP, let's say, or physician, internist, or surgeon need to be a small geriatrician. Why I say that? Because we need integration in the primary level now. So there is integration of the care in the hospitals, there is integration in the primary care, and we need also technology to do the vertical integration, hospital with primary care. This is my opinion, I think that Greece needs to do many steps to this, because we have not the services and the infrastructure to support all this. But it is a need because of the aging population, especially in Greece.
Maybe one additional intervention, if I may. I completely agree with you when you say that it is crucial, really essential, to promote development of geriatric medicine within the academia, within the universities, because there is the place where everything starts, actually. This afternoon we underlined the importance of education, but I would also add research in older people, because from our society, from European Geriatric Medicine Society, we are really trying to foster geriatric medicine in each and every aspect: education, professional skills, but also research, to producing evidence that we all can rely on in different settings of care, whether is it a primary care or a hospital care or even nursing home. If we rely on evidence and not on eminence but on evidence, it will improve the quality of care and the quality of, I would say, approach to all the people and all the patients.
Okay. Yeah. I'm looking at the geriatrics like working in a team, and the word for geriatrics from my point of view is holistic. And I have a question, so this is the first question, and not question, opinion, and I have a question regarding education. I don't know in other countries, but in Romania, for example, the diploma is not available, for example, in France. I mean, working directly as a geriatrician. So I don't know with in another countries. So diploma as geriatrician in European Union. For example, in France, you have to take the l'avis du Conseil national de l'ordre des médecins.
Well, I think it's a specific question, just to say that whatever, even in France, even for people that follow the French system, is l'ordre des médecins, who the structure that provides the validity of a specialty. It's not, let's say, the medical schools. The medical school provide diplomas, the medical schools provide education, but the officialization of a specialty, and in order to have homogenization, because people come from several countries, from several medical schools, whatever, so there is the l'ordre des médecins, which is, how do you say that in English exactly? It's ο σύλλογος, ιατρικός σύλλογος. the medical council of each region and the national medical council that gives the authorization. So, but this is something, yeah, specific. It's not only for Romania, actually. It's for most of the countries. There are many criteria, which administrative criteria.
Well, I would like to say a few things briefly because I have a need, you know. Regarding the undergraduate education, I think that every faculty of medicine should have geriatrics as a subject at some year. It doesn't have to be long curriculum, but it has to be done. And we have some European undergraduate curriculum which was published in Age and Aging. I think that also a British Geriatric Society has some curriculum for undergraduate students. Yes, and okay, I think maybe this undergraduate which was published in Age and Aging, maybe it's too ambitious for every country to be implemented, but I think that we have to have each university which produce medical doctors, we have to have geriatric, because with aging population, every physician, unless is a pediatrician, which Dr. Bogdanovic said, or obstetricians, should have some basic knowledge in geriatrics. This is regarding the undergraduate education. Regarding the postgraduate education, we still have a great diversity across the Europe. Some countries doesn't have a specialization in geriatrics at all. Some does. Some countries have geriatrics as a subspecialty. And first we have to, it is of course hard because of national societal, national legislations to unify it, to have some postgraduate curriculum, but I think that, for example, UMS is also working in collaboration with UGMS on this postgraduate curriculum. And that will be all from me.
Just picking up on what Professor Petrovic elaborates on the need to foster research. So it goes vis-a-vis fostering training and education, because the best way, as we know, to teach and train these physicians would be to conduct research, to present research findings. And if I pick it up from a public health perspective, talking about the burden of disease studies, so if we want to have these comparable data, cross-country comparison, but also within the same country to have this time trend analysis. So the best way would be to strengthen the research methodology in the first place, because we are not doing so well in terms of measuring, assessing probably the burden of disease among the elderly. If I simply take the example of distribution of disability weights, for example, there is a wide range of, it's very wide variety of, let's say, different countries, you know. Data are very, to cut it short, it's very hard to be comparable. Let's say many of these diseases, let's say when we calculate the burden of disease, they are self-assessed parameters, and different cultures, different perspectives, they do report differently. And therefore, in the first place, we need to standardize the methodology in order to provide with cross-country comparable data, and so as eventually we come up with sound burden of disease studies comprising these elderly people population, let's say 65 plus. Thank you.
I think Professor Finbar is right. We cannot offer a solution for everybody. We have to adapt different solutions to different countries, because you have so many circumstances, cultural, social, economical, and so on. And also, as Professor Benetos said, we have to have a progressive approach, because the condition of older people is changing. So have to provide a specific service for a specific situation in a certain moment of time. So, but also regarding this inpatient or hospital-based geriatric medicine, you know, it's very difficult to provide so many beds at the beginning when you have to change a system. Policymakers do not accept to offer you many beds. And that's why I said, because we confronted with this problem. And they accept more easily to develop first an outpatient network, and then it will come easily. Because we had some experience in our country. For example, in western part of Romania, one of our colleagues, younger colleagues, went there, and at the beginning they looked suspicious. What is geriatrics? This is not important. And then very difficult to obtain 7 beds in the hospital. And when they've seen the outcome and the efficiency of the activity, okay, it's not enough. Let's give her more, 20, 30 beds. And they need more geriatricians to employ. This is the idea, because it's not possible to persuade policymakers by numbers or by anything else. And we have an advantage, maybe, and I'm not sure if in other countries the same. We have a hospital funded by local communities, local authorities. And if you persuade local authorities that you are efficient, then it's much easier to get to a hospital-based solution. But as I said before, different countries, different circumstances. You cannot have a single solution. It's not very easy. As you have seen, even for other countries, for each country, it's not very easy. In France, we had a lot of problems. In Germany, a very rich country, they don't have geriatric medicine recognized as yet. Also in Austria, you know this. So you have to know that not only the high economical standard or status will offer you the opportunity to develop geriatrics. There are a lot of things that come here, as Professor Fima said before.
I would like to just to add one thing. I agree with my colleague. I don't need the mic. I just disagree with you. Our societies are different, but the needs of the elderly are not so different. So we have to have the same goal. Maybe we will come to that goal through different paths, but the goal should be the same. That I would like to add that.
I would like to add something on that. Yeah, but to start, you're right. To your question, my answer is very clear. When someone says, not for Romania because there is a tradition, but let's say, there's many things, but in a country, let's say there's nothing or almost. I say, start with 2 things: mobile units, and first also train some people who were abroad, whatever, and they create a small first, core, and then try to implementation of this structure, mobile units, to give the expertise. And slowly by slowly, those who receive the expertise are happy. Believe me, we are now, I'm 20 years almost in Nancy now, 18 years. And now we are, so there's such a big demand from the other departments to go there to resolve problems. Also, the geriatric department now is the only department that these last years, because the crisis in France of the social system, the medical system, hospital system, the only department, department that we have an increase in beds and some specific units is the geriatric department. Why? Because our unit, for instance, an example, that called Unité d'entrée directe means a unit that people do not go through the emergency room, but come directly. Everybody is happy because it's very, so everybody is winning. Everybody wins in this. So as also Finbar said very well, it's not like that today you go and say, we need 1,000, of course. The final goal, I agree absolutely, more or less the same. Not because only there are much more old persons today, but, and it's justified, the needs, the expectations of these people, it's completely different. When I finished medicine, I arrived in France, we called an old person 65-year-old person, and someone who at 70 or 75 had no even memory. It was okay, it's gerontic dementia, that's it. He cannot walk, of course, it's not heart failure, it's just because he's old. Expectations changed, so it's very nice, it's very good, we have to adapt that. So for that, the needs, and progressively, if you start with mobile unit, training people, and then you start with a day hospital, and the hospital and the society see that it's interesting, and also maybe some units to take patients directly, or to have a mobile unit in the emergency room as we have to evaluate them, and progressively this shows that it's interesting, and even financially, our department presently at the University Hospital of Nancy is the most beneficial department of all the entire hospital, which for many years everybody says, oh, this is the thing that just all the other departments has to pay for geriatrics because it's believe me, you can see our numbers, it's our most beneficial department. And so future is with us, and present is here and needs us, believe me. And just to finish, also, most of our colleagues, my age, 60, they come to us, they have their parents that they need us. So we can get benefit from that also. Thank you.
One final comment here. Sorry?
No, I wanted to know if without the state support, your model can be realized or not. You are the model that you explained. Without the state support, how for Serbia, for example, they are making, for many years they are working. Is it possible to achieve this model?
One of the things that state-funded health services want to do is to become more efficient, not increase their revenue. It's a very different motivation. Coming to the question of beds, when I started as a consultant at St Thomas's with 3 consultants and we had 200 beds, and we had, because we inherited old, long-stay hospitals like some of you have inherited, and we spent half our time doing general acute medicine, half our time doing geriatric medicine, so that's 1.5. We now have 120 beds and 18 consultant geriatricians. So what we've done is we've demonstrated that done badly, it's very, very inefficient. Very inefficient. So it's a question of finding out where do other people agree there's a real problem of quality and efficiency, and try and solve that problem. And where people see it is going to be different in different places. Not for good reasons, but you have to work with those. There won't be good reasons, there'll be local reasons why they see this is the problem, we must solve this. You know that in the long run, actually that's a bigger problem, but you have to solve their problem.
The very last comment, Nenad?
Okay, I don't want to conclude, but I don't want to sell the model of Sweden. Sweden make a 1992 reform of geriatrics and still working on this. And first was no more than 13 days in the geriatric hospital. So if you are longer than 30 days, you are ineffective. So they switch the responsibility on the primary care. So I think we all agree that we need geriatric expertise on the all vertical level, primary, secondary, tertiary, but we also need on the horizontal level, as you mentioned previously, multi-professional teams. Don't forget physiotherapists, speech pathologists, stomatologists, all need the knowledge of geriatric on the horizontal level if we want to work in the big team. So maybe politically, can EUGMAS initiate this type of thinking for those countries here, that we can insist on the understanding what is verticality and horizontality can be achieved in those countries to get some kind of any idea. And then the next step is probably European Commission, which can insist, if we already have 10 years period of aging, healthy aging, that it can be very stimulate for those countries. But country has to come with idea, because we are really different in the culture and the infrastructure.